Hello, everyone, and welcome to the third virtual interactive program featuring the Eaglet Eye Surface Profiler. I'm Tom Arnold, and I have the honor of being the moderator of this series. Why are we here? What is profilometry-based specialty scleral lens fitting? And the idea of this and the point of our series is to get everyone, all the contact lens practitioners out there and experts, more comfortable with the concept of being familiar with measuring the sclera, measuring the landing zones and the elevations, so that we can have better fits, reach our endpoint more precisely and quickly with more patient comfort. And so module 1 with Jason Judlicka went over the basics of scleral lens fitting. Level 2, Barry Leonard from California showed us some tips and tricks and some examples of how you can improve your scleral lens fitting. And tonight, we're really honored to have Dr. Sheila Morrison, who's going to take us through advanced scleral lens fitting and problem solving, because it's very easy to start fitting lenses and have some success, but what happens when it's not so easy and you do run into some problems? So a little about Dr. Morrison. She received her doctorate, master's in vision science with a focus on scleral lenses, and did a residency in cornea and contact lenses at the Pacific University College of Optometry. She was on the faculty of the University of Houston College of Optometry, where she facilitated education and research in the contact lens and cornea service. And that's where I had the privilege and pleasure of meeting Dr. Morrison and working with her there. Dr. Morrison and I have lectured together on several occasions, and I think there's no one better than she to really get into advanced scleral lens fitting and problem solving. We wanted to make her an honorary native Texan, but she decided to go back to her home in Canada, where she raises her beautiful young daughter, Ava. And she's practicing now at the Mission Eye Care Center for dry eye and corneal diseases in Calgary. So Sheila, it's a pleasure to have you, and we welcome you, and please take it away.
Well, thank you so much, Tom. I certainly appreciate that kind introduction, and I miss Texas. That was a wonderful experience to be at the college with a lot of our good friends and spend some time a little closer to your practice as well in Houston. And today, I'm also very grateful to be able to have this group to all of you out here. We're all here at this point to be taking steps to better our patient care. We're all on a hunt for better technology and better results for our patients. And today, with the advent of not only better lathing materials, lathes, we also now are in the era of digital technology. And I really found a big shift, I guess, from when I was in the United States, in Texas, using, profilometry, in particular, the ESP used it for years when I was in the US. When I initially came back to Canada, we didn't have access to that technology. So now that I'm back on track here, I've seen again, just one more time, how important it is, to take the technology that's available by the horns, use it, embrace it. And my role today is really to take things to the next level and share with you some of our clinical experiences. We're going to go through complications when it comes to scleral lens fitting, things that we encounter commonly in the clinics, and give some tips about how to handle these complications. So hopefully each of you will come away with, at least one or two things to either reinforce things that you're already doing in clinical practice and maybe add to your arsenal of different tools and techniques that you can use to provide better outcomes for your patients.
Sheila, forgive me for interrupting. I forgot to mention that we will be taking questions in the chat box through the presentation, and we'll be going through and answering those questions at the end of the presentation. So use the chat box at the bottom of the Zoom thing. And again, sorry for the interruption.
Oh, thanks, Tom. And at any time, this is meant to be somewhat interactive. Of course, it's a little different than being live, where we can really see each other and spend that time. And, I'm really looking forward to 2021, the rest of this year, and moving forward to get back in person. But for now in this platform, certainly, Tom, if you see any questions that are appropriate, just interrupt me. I'm happy to take them as we go, or like Tom said, we'll just save them for the end. Now, we wanted to do just a very brief recap, and I would encourage those of you that didn't have a chance to catch modules 1 and 2 to take a look at them. They're not long presentations, but really great things that you can learn from each of them. In the first module, we learned that the biosphere elevation map is very good for evaluating scleral shape and diagnose and quantify local elevations. A brief recap of module 2. In the second module, we then saw how checking the sagittal height differences of the eye will help us to decide what type of lens design is most appropriate for our patients. And so again, these lectures are available. They are there for you online, and toward the end, we'll make sure that we give instructions on how to find them so that you can catch up if you didn't see the modules 1 and 2 in this wonderful series. Now, just as a little aside, I know I had a pretty crazy clinic and didn't quite get to making a poll. This was intended to be a poll question. So if you want to just pop in your chat, as Dr. M, a cartoon character superhero, so we have Wonder Woman and we have a pumpkin. And I just wanted to start with where this came from. I, in the past, have spent many, many long hours, as we all have, burning the midnight oil on these types of presentations and working. Particularly since I had my daughter, who's a toddler. I like to shut it down at midnight. And so the last couple of days I've been sending Elena from the Eaglet group, a message with, here's where I'm at tonight. No more. It's midnight. I turn into a pumpkin. So she sent me this. And then at the end, again, yesterday, Tom Arnold sent me this Wonder Woman when he caught a look at what I had intended for all of these case reports at the end. 20 cases might be a little much. And so we've narrowed it down a little bit, but we're going to make sure to move through and get through some great cases at the end. Tom, are there any answers in the chat? Is there any kind of poll, any sort of like resolution to this question? I'm hoping superhero. Ooh. I can't hear you, Tom, but that's okay.
Sorry, I muted myself. Let's see. One vote for pumpkin superhero and another for superhero, and I'm in a second superhero. So
love it.
I think, Sheila, you qualify for the latter. Superhero you are.
Love it. So fun. All right. So again, when it comes to dealing with complications, I always look at scleral lens fitting. Actually, you know what? Any medical device that we're fitting on patients, anything that we prescribe, any advice that we give, we have a responsibility really not only to provide options, but also to avoid train wrecks. And a lot of the population that we serve when fitting medical contact lenses tends to be at times high-risk populations. A lot of the patients that are best served by scleral lenses have had surgeries, they suffer from ocular surface disease, have had trauma. And so when it comes to fitting scleral, step 1 is actually physically fitting these lenses so that they're comfortable, providing good optics, but we still have to pay attention for complications so that we can keep the eyes wearing these devices very safe. Now, complications, meaning some of the things that we're kind of looking at the differences. We have challenges when we fit scleral lenses, we have complications. When we head into the realm of complications, we're looking at, secondary diseases, conditions aggravating already existing ones. For example, patients, and I do case reports to kind of share with you, patients with a low endothelial cell count. Sometimes wearing a contact lens can aggravate these conditions. Now, both challenges and complications can be overcome, certainly by being, number 1, aware of what they are, and then kind of understanding what the tools are to best remediate them. Anytime that we're looking at a complication or a challenge, really what it comes down to is we are looking at that fitting relationship between the eye and that device. So the plastic, in the image we see, a scleral lens with vaulting over an irregular surface, but that tissue beneath it, the cornea, obviously very important. The lens lands on the conjunctiva, and there are a variety of different tissues that can be affected by lens wear. Now, the anterior sclera is very impacted. The physiology varies from patient to patient. Every person has their own unique fingerprint. And so a lens fitting the same way on one person versus another may behave very, very differently depending on their physiology and depending on the underlying etiology of their condition. One of our major complications that we deal with when fitting contact lenses, and in particular sclerals, is actually a physical barrier. Things that cause irregularity in the ocular shape present challenges for us when we're trying to get a lens to land comfortably, safely, and kind of in alignment with the anterior eye. One of our goals is to prevent things like compression. We don't want any lens touch. We'll go through this in a few other slides just to kind of show and give an outline for, no mark left behind. But typically in clinical practice, some of the most common complications related to the conjunctiva or the scleral shape with the overlying conjunctiva are, lumps and bumps, things that perhaps will be an elevated area of the eye so that when a lens is placed on it, that elevated spot may be under compression. When we fit lenses on elevated spots without accounting for them, we can create all kinds of problems. So a pinguecula that you see in this picture, starting out as just an elevated bump, can become inflamed, painful, and it can grow. And so sclerals certainly need to be fit with caution. And today we do have the technology to provide and create these amazing designs to actually vault over and most appropriately fit shapes like this so that we do avoid that compression, friction, and touching. Now, in our clinical practice, and I know that a lot of you out there fitting sclerals fit lenses on corneal transplants. And to be quite honest, this is a population that again comes with one of the greatest responsibilities because they are high risk. Oftentimes PKP comes with concerns such as a graft rejection, vascularization, edema. Edema is probably one of my number one things that comes up in patients that have had surgeries like a graft. And so when we have a lens inducing things like or triggering or contributing to rejection, blood vessel growth, of course, we know we don't want blood vessel growth in the clear cornea in any patient, whether they're post-surgical, whether they're in a soft lens, scleral lenses, we need to ensure that they're getting adequate oxygen to prevent these types of things from happening. So how do we measure? In clinical practice, one of the things that is highly important, so important, is baseline data. And so anytime that I have a patient in the clinic coming for a scleral lens fit, whether it's a PKP, really anything, we take baseline data, including, whenever possible on eyes like these, an endothelial cell count. Sometimes it's helpful to know that in advance, and anytime that I can, any referral from our ophthalmologist in town, local optometrists have all gotten to know our practice, and they know that if there's any way that they can send me that endothelial count, that's great, because that will save them the time later. I'm going to be asking for it. So collecting data such as an endothelial cell count in a PKP, really important so that over time, over many years of lens wear, patient who's 50 years old and starts wearing sclerals at that point has decades ahead of contact lens wear. And we do need to monitor wherever we can to ensure that we're not creating changes to the layers of the cornea that could potentially cause adverse complications and reactions. We check for edema, usually whenever possible, by measuring a baseline corneal thickness prior. This can be done with a variety of instruments, but having that baseline, sometimes, if you do an evaluation on a patient, fit them and forget, it's kind of hard down the road to be looking for a very subtle edema. Of course, there are clinical signs that we see, we'll see endothelial folds. In some cases, you can see the swelling happening, vision changes, but in some patients, the very first signs are really digital. And so collecting that baseline is absolutely important in these patients. I take photos of patients before we put lenses on them so that we always know their baseline. We find that a lot of these cases, especially in PKP, are going to have kind of a baseline sort of, corneas that aren't necessarily smooth and happy. And that, oftentimes is their baseline. It is what it is. We can't expect an eye that's had multiple surgeries and grafts to have no staining, but we do want to ensure that we're not causing lens-induced staining. So having a good baseline. Anterior segment photography is also great to prove and show that we're not causing increased vascularization into the cornea. And certainly, absolutely, we don't want to create anything with a lens that moves blood vessels growing through the cornea past that graft-host interface in these patients. Another very common complication is related to midday fogging. Sometimes in patients, actually more than sometimes, based on the fitting relationship with an eye, will create kind of more of a suction fluid force if we have unequal spaces, and in particular spaces that are too great. So for example, patients that are fit based on maybe, whatever your choices are for your lens fit relative to that eye shape, when we create, in particular, excessive inferior clearance, which is quite common. As we know, scleral lenses tend to kind of go down because of gravity. The big belly hangs low is how I think about it. We can have a lot of complications in this area, such as increased conjunctival prolapse, meaning that that tissue on top of the sclera kind of sucks up into the area of that fluid force underneath the contact lens, and usually is worse inferior. We'll show a picture in a second here. Prolapse usually kind of goes away after the lens is taken off, but during that time where the lens is worn, if we have excessive inferior clearance, we can actually create an area of hypoxia, meaning that we're increasing likelihood of having blood vessel growth. And that's not just in a PKP, that's in any patient that wears a scleral lens. And so that excessive inferior clearance is something that we certainly want to watch out for and remediate if we can. Midday fog is something that typically patients will experience after some amount of lens wear. It may or may not happen, in all patients. Probably at least, I would say, 30% at least of our patients. Less now with better, products and materials, and we're fitting the eyes a little closer to the cornea now than we used to. No more 400 micron, spaces over the cornea with that extra fluid force and more space for fog. But, if we can reduce the space, including that inferior clearance, that's a big helpful thing that we can do to prevent the fog and prevent the prolapse. Another complication that can be created by a scleral lens is corneal staining related to bearing. Now, contact lens 101, anytime that we have a cone in a patient with keratoconus or an elevation on the cornea, well, number one, we don't want to be bearing on that space. We know through literature and evidence-based for many, many years that we can actually exacerbate staining, or scarring in an area that we certainly do not want to have. Usually the apex of an eye with keratoconus is somewhere near the visual axis. And that's actually what can create the biggest issue for us when trying to give good vision to a patient with keratoconus, scarring. Anytime that we have a lens that touches the cornea where we have nerves and are sensitive, we can also create discomfort, and patients will find that the lens is not comfortable, they can't wear it. I'm very, very safety conscious. I know, rule number one, when it comes to contact lenses on any patient, safety first. Whenever we create a spot of bearing, we create a wound in a lot of cases, and that opens the cornea up to microbial keratitis or other infections that can then pass through that cornea, especially in eyes that are just a little bit more compromised. Apical, limbal, and scleral bearing also extends further out. So certainly centrally and over the cornea, we don't want to create any areas of touch. What about limbal bearing? We know that we have the highest amount of stem cells in that area, in that kind of limbal area. The mid-peripheral cornea is very important. And patients not only will be uncomfortable, as you can see in the bottom left picture, the way that we historically and continue to best evaluate for limbal touch, which we don't want in a scleral lens patient, is by utilizing fluorescein. So we have a scleral lens with fluorescein under it, and that black ring kind of along the outside edge matches what we see if we were to take a cross section in the OCT beside it. The lens is actually touching down a little bit inside the limbus. And so not only are we touching in an area that we have corneal sensation, so patients are definitely less comfortable, we are also creating areas that we can trigger things like limbal stem cell deficiency and create disease in the cornea or defects in the cornea related to the fluid pumps. And ultimately, we're creating a situation that could end up in an unhealthy cornea. Now, a special note when it comes to bearing, patients with corneas that are insensitive and that are not sensitive, for example, in neurotrophic keratitis, patients that have had a lot of surgery sometimes do not have as much sensitivity in their cornea. And so, for example, this light kind of epithelial defect that you see can become very, very deep and kind of a big injury that can become a huge problem. People really realize that they're having the problem. And so again, it's our job to be checking every single time with fluorescein and taking lenses off every time so that we can make sure that we're not creating these areas of touch. When the lenses bear too tightly on the sclera, this translates to discomfort as the biggest problem. Patients will struggle with comfort while they wear the lens, and they will also suffer from rebound hyperemia, red eye, lenses come off and they flush really, really red. Patients often ask, is it normal to have a ring? And is it normal to have an impression ring of that lens? In a lot of cases, we cannot avoid that altogether. But usually today with the lens designs that we have available to us, we can minimize it just by matching the shape of the eye to the best fit lens in terms of the design, in terms of, the edge itself, where we can avoid that really tight fit. Corneal staining can happen based on poor lens fit. Another reason that we get corneal staining is related to toxicity. We see this every single week in the clinic, almost daily. Every time a patient comes in, if we can check with them and say, what kind of solutions are you using and how are you using them, we can uncover a lot of different things that happen in the clinic. Toxicity comes from oftentimes using products that have preservative in them. And one clue when we're staining patients to determine if we're getting staining from the lens touching down in that kind of induced sort of touch creating the staining, or are we getting a toxicity reaction? Toxicity looks more like in this picture where it's almost global. It'll go across the whole cornea, superficial in little spots. And that is a sign of a toxicity reaction that would be no different than if a patient was not wearing a contact lens. And so these are, again, staining can be a complication that we see quite often that we certainly need to manage. Back to neovascularization. Now, today we have some amazing tools, and we'll go through that in subsequent slides, but the biggest issue that happens with neovascularization, of course, it's caused by hypoxia as a bottom line. Sometimes we can get neovascular blood vessel growth related to mechanical stress and dry eye as well. And so again, really watching out and imaging as you're having a patient wear a contact lens, any lens at all, but definitely a scleral lens is something that we need to watch out for. So those are just some general complications. Another one that comes up a lot in the clinic is surface wetting versus fogging. Midday fog is very different than a lens that becomes foggy from a non-wetting front surface. And that's something that we'll talk about in some of our cases. But essentially, there are two different types of fog, we'll say, that patients will present with. One would be fog that causes blurriness from underneath the lens. So that would be more our midday fog, debris that gets underneath the lens from external tears or from the external environment. Midday fog, we have many great scientists currently investigating exactly what exactly is the fog. There's a lot of lipid in fog. Sometimes patients will wear lenses and report that the lenses are clear when they first put them on. And then after some amount of time, they'll report blur. And you can almost see the fog underneath the lens. Just a little bit of kind of almost white, that when the lens comes off, there's kind of white debris under. That's midday fog. That's very different than the front surface not wetting. Front surface wetting, again, needs to be managed in a different way, and it's usually related to solutions and the chemistry between the tears and the plastic material itself. Now, how do we manage? Now, when it comes to conjunctival irregularities, one of the greatest tools that we have to manage and prevent the complications that can happen from lumps and bumps on the eye, from elevated spots, is number one, to measure. If we have access and if we can, corneal topography, profilometry, taking a baseline measurement to really understand that ocular shape prior to fitting a lens is essential so that we can avoid triggering these complications. Sometimes we can utilize smaller lenses. So for example, if we map or we look with our slit lamp and we can see that, maybe there's, a bleb in a glaucoma patient and it's far enough out, but still kind of, maybe a couple millimeters from that limbal zone, if it's far enough out, we could see that, we may be able to use a smaller lens. Same thing goes for like a pinguecula, for example. So, in this photo or in this image on the right, you can see an area of elevation in the profilometry map. And if I saw this, what I would do is have a list of kind of lens designs in my mind to think about, how can we best suit this eye shape? Do we need a large diameter lens? How big is their HVID? Do we need a size that's going to have to touch that pinguecula? And then what do we do about it? Do we vault it? Do we, put in some kind of other, notch or something else to avoid that space. Use a freeform lens to totally glide right over it. Or could we use a smaller size lens? And in a lot of cases, the simple path has a smaller lens if it works. Now, sometimes we actually need to go larger. And so if the height of that elevation or that lump or bump is actually not super high, where it might be reasonable to vault over with a larger lens that would maybe glide over it that way, that's a great technique as well. But again, the bottom line when it comes to ocular shape is evaluation first if you can. Really get a good understanding of what this person with the eye shape is. What is the, where are the elevations located? How high are they? And that helps us in choosing the most appropriate lens design. Now back to our edema, graft rejection, and blood vessel growth. Patients who have had transplants or other major cornea surgeries, again, just from the nature of their procedures they've gone through, they're already at risk for having poor fluid pumps, and with or without a lens may be at risk for things like edema, rejection, and blood vessel growth anyways. And so whenever we fit these lenses onto these types of eyes, our goal is to really do everything we can to assess the risk and then provide devices that will best suit the most oxygen. Some of the tools that we have today are absolutely incredible. We can fenestrate lenses, we can put channels through like a river to provide oxygen and tear exchange. Tear exchange is really important in these types of patients to promote healthy oxygen to be able to recycle over the eye and provide it the oxygen that it needs. The other thing, again, we want to avoid friction and trauma. On eyes that are compromised, a lot of the shapes of these eyes, of course, have more of the oblate shape where we may have a central area at an elevation, a mid-peripheral kind of button that has a height that's high and it may drop off suddenly. We want to avoid that mid-peripheral touch, absolutely, because touch in these areas can also increase the likelihood of edema, rejection, and blood vessel growth. And one of the things that's we use a lot, and I know most of us collaborate with ophthalmology as well, but whenever it comes to high-risk eyes, we always like to collaborate. So often our patients will split their time and see a cornea specialist to, again, do a double check for us, make sure that they're happy with the health of the cornea, maybe in ways that we don't necessarily have in our clinics, like endothelial cell count, and just to ensure that there's nothing that is happening related to the lens wear. Now we just went through all this. So this actually is a beautiful photo, just to give another idea, sort of to re-emphasize, and I've got a few more to say to really kind of show when we see an image like this, this is an eye obviously that's very steep and very proud. That area, trying to fit a conventional lens that has a uniform shape over it, you can imagine where the arrow points, that area is at a high risk if we don't find a way to minimize the space. And so again, the profilometry can help us to identify that early on so that we can choose the best devices and put in all the precautions that we need to, like fenestrations, sometimes even reduced wear time, depending if the patient is prone to this kind of swelling. Now, HVID and VVID has become absolutely essential in clinical practice when fitting scleral lenses. It's not something that we used to look at, but certainly in the last couple of years, we've really started to pay attention. Because in most cases, the HVID and VVID, meaning so the horizontal iris diameter versus the vertical iris diameter, they're not always equal. And so if we select a lens design, for example, on an eye that has a difference in the horizontal and vertical limbus, and if we don't accommodate for that in these types of patients, we can be adding to that excessive inferior clearance. Now, we always want to land at least a little bit out from the HVID so that we don't induce any limbal touch. In the image, you can see it's actually a beautiful fit where we have that junction. You can see a cross section with an OCT to identify where the limbus is, and lenses should not land inside that area. Now, another thing that can contribute that we watch for when it comes to preventing that likelihood of having inferior clearance that's a little bit too much is looking at corneal topography. We can use a ESP to do this by utilizing, usually I look at an elevation map that you can see in that central portion of this image to kind of show us where the height difference is. In orange and red, these are areas of higher elevation in the cornea. green and blue are areas of lower elevation. And so if we were to imagine placing a lens on top of this eye, where we have green and blue being further away from us and red being closer to us, the lens is going to touch down first on the area of the higher elevation, so the red. And so we're looking out for extra space in those spots of blue and green, just because we know that that's a little bit further away. And so again, there are lens designs today that we can use to help to reduce the amount of inferior clearance that we see. But again, looking at topography is really important for us to be able to best manage this. Here's a beautiful photo, if I do say so myself, of my patient. Just realized that we've got lots of great photos from great practitioners throughout all of these lectures. And this is what that conjunctivochalasis or the prolapse looks like. In patients where we end up with that big belly lens that hangs kind of low, maybe lens decenters a little bit, or the cornea is, really steep and kind of falls away. This is what can happen. Now, conjunctival prolapse sometimes cannot be fully avoided. The way that we manage is we try to reduce the space around the limbus as much as we can in those areas so that we're not having excess space that pulls with a pressure force, and we minimize it as much as we can. We can minimize it by using lenses that are able to adjust the limbal zone in quadrant specific or toric zones, or even a free-form design that can more closely, if we saw that patient with that prolapse, what I actually did with this patient was shift that inferior zone up. This is a free-form lens that we have the ability to do that, data-driven, of course, using scans from the ESP. And by measuring and, relative to a lens that goes down, we have a big belly pulling up that tissue. In our next lens, we can actually shift it all up so that that limbus is not quite so droopy and baggy down there. Now, in some patients that suffer from prolapse, and again, that area is at a higher risk for blood vessel growth and not enough oxygen, and then of course, discomfort and redness, we sometimes need to manage other conditions besides just the contact lens fit on its own. In many cases, we actually refer for a resection if we've done everything that we can to get a lens to fit appropriately, and we still end up with this and we start to see complications from it. So lack of oxygen, discomfort, blood vessels growing. Keep a resection in your toolbox as something that you could partner with and refer for to just have that extra tissue resected. And sometimes that is very helpful in increasing comfort and likelihood of a patient to be successful with the lens. Dry eye plays a role as well in these patients because inflammation in dry eye typically comes along with a certain amount of conjunctivochalasis, so that excess tissue. And it, certainly by managing dry eye, we are able to get better outcomes for our patients that way too. Midday fog, as we talked about 30% of our patients will fog at some point. And the first thing that we look at is the lens fit. Now, we want to make sure that we're minimizing a big bowing space at the limbus. So the top image is a cross section of an OCT, and you can see a big difference. The kind of cloudy, sort of dense looking fluid between the lens, which is on the top, and then the cornea, that bright white, and then out to the sclera, the space in between, when we take an OCT, we can actually see midday fog. And that helps us to differentiate between the non-wetting on the front surface, where a lens may have kind of a dirty windshield, versus true midday fog. Patient symptoms are often the same. They come in and they say, my vision's blurry and I don't like it. So a clue that we're getting midday fog is lens is clear initially. After some amount of wear, we end up getting blurry vision. Maybe we look at our OCT, try to figure out what's going on, and bingo, in this case, we actually can see that there is an excess and a mismatch of that kind of smooth ocular shape, where we can decrease that space at the limbal zone, resulting in a fit that looks a lot more ideally like the bottom photo. And in many patients, that's all it takes to reduce the fog. Excessive clearance over the cornea centrally can also create fog, and there's a lot of different factors in that. When there's a device put on the eye actually reacts to it in a way that says, this is a foreign body. I don't think I want this on my eye. Some of the things that are actually put out by the cornea are, substances that are almost an inflammatory reaction. The fluid force beneath the lens plays a role in that as well. And so by keeping a nice clearance that's even without excessive space, we can really reduce midday fogging. Midday fog can also be remediated in a lot of cases by the solutions that we use. So we also, once we get a great lens fit without excessive limbal clearance, make sure there's no edge lift that's allowing external debris to get under that lens, then we usually take a look and think about things like allergy. So often I'll put patients on allergy drops or an antihistamine. We also look at using a more viscous solution in the back of the bowl. So maybe a drop of Celluvisc on the bottom, drop first, and then fill with saline, so that the saline, when you put the lens on, saline falls away and we're left with just a little thicker solution in the back. And that fluid kind of pressure system changes enough that in some patients, the midday fog is decreased, if not eliminated. I have a few tips. So these are a few, there's so many wonderful things that we can learn from each other. And that's why I'm looking forward so much to having the opportunity to get back in person, where we can sit at the bar after these conferences, talk about scleral lenses and learn tips and tricks from each other. Here's a top 5 off the top of my head, just to share with you things that really have been helpful in clinical practice in our office. Number 1, I've had many times or enough times that we spend, a full office visit evaluating a patient for a referral for one eye only. And then somewhere down the road, they end up wanting a device on the other eye. Perfect example is mild, maybe moderate keratoconus, satisfied with a soft lens, and an advanced case on the other eye, fit that first eye, love the comfort and the vision in the scleral. A couple months later, they want a scleral on the other, and you have to bring them back in. Now, it's always great to just we do a workup on both eyes 100% of the time, just so that you have the data. It's always great to go back to do it. And the only exception would be a non-seeing eye, prosthetic, an eye that's never going to need any protection from a scleral lens or to be fit with a lens at all. Tip number 2, quality data in is quality lenses out. So the lens designs and our outcomes of any medical profession, really when we're collecting data and using that data to make decisions, to design lenses, for example, if we don't have great quality going into our designs, we don't see great quality coming out of our designs. And so putting in the extra time with profilometry to make sure that our data in that we send in to create these lenses and the data we're looking at to make decisions about lenses is high quality. Train your technicians, they're your greatest tool, and take the time to do that, because taking that time at the beginning will certainly save time in the long run and reduce remakes on lenses for sure. Considering risk versus benefit for all medical devices is absolutely essential. Some patients we don't fit. I just had a patient, a really sad case this week, actually last week, bilateral transplant on one eye, the other eye had some other complications from a trauma. That's everything that I want to do is to get this patient a bit better vision and put them in the lenses that they want so badly, had failed fits in other offices and really came to our practice for us to be heroes. And that's what I was prepared to do. Looking at these eyes, number 1, if visual acuity potential is not high enough, so maybe we're only gaining a couple lines on a high risk eye and they don't really notice a difference in the vision. Eyes that swell with or without lenses, for example, a patient in your fitting, if you let a lens sit for an hour and it swells right away, you really need to rethink about, is this a great candidate for scleral lenses? It doesn't happen very often. More times than not, we fit. There's so many options, but always consider risk versus benefit. Is the visual acuity worth it in their daily activities for the cost and the time for all of us to be fitting lenses on these eyes? To the point of time on training your team. This is one of my favorite points when it comes to our team at the office. We put in lots of resources, or we think we do, and we love to spend time with our technicians. And it might be a little selfish, because what that results in is better patient outcomes, more efficient exams. And so definitely in your practices, or, if you have the opportunity to have teammates or, colleagues that are working with you to fit these lenses that are specifically scleral lens technicians, that can really save a lot of time in a practice for sure. And connect with your labs. I have to always include this because your lab partnerships are one of the most valuable tools that you have. The relationship is key, and it kind of goes both ways. Being understanding with your labs pays off in the long run to kind of get, favors back when you really need it. And ultimately, we're all here because of our industry, to be honest, in seminars like this. The Eaglet group, for example, putting out education for all of us and keeping everybody up to date on all of the latest technology. Again, staying connected and choosing the labs that are close to you and having a great relationship with them will go a very, very long way in clinical practice. This is a note on quality data. So this is an example of data that probably would not be suitable. The ocular surface certainly affects the scan. So there are some dry eye patients that are very difficult to measure. And that's because profilometry relies on a reflection-based system. Sometimes, more times than not, we'll put one drop on the eye just to smooth it over. You never want to use too much, like really, really thick drops, because that can actually alter the shape a little bit. But whenever possible, I would redo this, and I would not try to make a lens from this scan. You can see the data is all bumpy and the scan is not good quality. Ocular surface does impact it. Now, the other thing that I notice a lot in clinic, not so much anymore, that we've spent time training technicians with the ESP, getting real estate is so important for lens design. Now, we don't need real estate out to 25 millimeters, but we certainly need enough space visible to create a lens. And so getting the lids open really, really wide is very important for getting good quality data. Finally, who is the patient that you're fitting? This is a topic that's very important in looking at not only the beginning, evaluating a patient in that ocular shape. We're looking at what are they a candidate for based on the structure of their eye, the optic, what is the underlying physiology, but always look at who this patient is more than just a set of eyes. This is a relationship that will go so far. So for example, really listening to a patient and their failed fits prior. You may get referrals or patients that you inherit or patients that you find that don't want anything to do with sclerals because they had a bad experience in the past. And our goal really is to listen to them. I feel that these failed fits absolutely need profilometry or some other form of scanning so that we can actually do things differently. Look at their scheduling needs, look at their ability to take time off for work visits. And one thing that's come up a lot in our clinic when working with freeform lenses, I've noticed that it's very helpful to do both profilometry and an imprint, sometimes if possible. Sometimes, data from one or the other, if you're thinking of creating a lens based on an impression or a digital scan like the ESP, there may be a flaw in one or the other. And so getting both, especially for patients that travel from out of town, is a really helpful clinical tip. Now, remember, your patient is the one to impress. And so something that's kind of neat about profilometry and all of our digital data is we can actually show images to the patient. So building the value in your practice. At the end of the day, the patient needs to have good vision, healthy eyes, and feel like they had a great experience, because today in a competitive market, there are other options for them a lot of the time. Usually when you have high technology and expertise and a patient feels like they're getting a good experience from the start, cost isn't much of a limiting factor. And definitely utilize what we have to show images to explain to a patient, okay, I need to put you in a scleral lens because this is your ocular shape. This is why another design may fail. It might fall off in this spot that's higher or lower than the other. We got to do this design because of your eye shape. Now, this next section to close, and I'll go through it so that we'll have some time for a few questions at the end. And I will stay a little later if anybody out there wants to stay and chat a bit, or you can email me and we can set something up. Sharing knowledge and really sharing cases. This is probably the most fun part. This is what I've been looking forward to anyways, is just showing off some cool photos of some patient cases that we've had recently that really demonstrate and show the utility of profilometry in clinical practice, and also a few little tips on, some things that came up for me and for our office that we were able to manage successfully. First of all, work them up. And so it's all about geography. I always like to include, and you may notice my nice background, maybe not. I was telling the guys at the beginning, this is a sunrise hike we did last weekend. The one in the photo is another photo from the Canadian Rocky Mountains, which is where I'm presenting from, just an hour and a half away, almost my backyard. But basically, when you look at a geography map, it's all in elevation. And that's one way that we look at how we design lenses, as you've heard in our prior sections of this three-part series. But cornea, what does that cornea look like? And all the way out to the limbus. So first of all, we work them up, figure out what they're a candidate for. Today, options in lenses are vast. We can adjust the power using torics multifocals. We can adjust the limbus and sagittal height of the lenses in quadrant specific or customized ways. We can add vaults, notches, channels, fenestrations. We're starting to do more with higher order aberration correction. And of course, our materials, coatings, and treatments are absolutely amazing today compared to, even 5 years ago. So kudos to our industry and for all of us for really embracing how we can move these great technologies into clinical practice. At Mission, we map, we analyze, then we manufacture it. We don't manufacture. So thanks again to the labs for doing that part of it for us and all the consultants that help us so much along the way. But that's generally the process in the office. Now, just as a very brief warm-up case, a very kind of simple way that we routinely, almost every day, have a new fit that we use the ESP to fit. This is a very basic case, a bilateral keratoconus. And just to give you a very quick kind of overview of what we do, get a patient in, do a typical workup, including make sure they have had a health exam, that we understand what the back of the eye is doing too, so that if there are any other reasons that they may not have good vision, we're aware of it at least. Work them up in whatever tools that you have for your scleral lens fitting, corneal topography, pachymetry, ESP, so we'll get a good measure of profilometry. In this case, this patient had this was just last Friday, never had contact lenses before and is interested in getting better vision. I don't show elevation maps, but definitely based on ocular shape, a much better candidate for scleral than any other soft or smaller diameter hard lens. Here's what we do. So I have my technicians work them up, take an ESP, and in the software, there are ways that we can actually predict a starting lens. This doesn't actually show the sagittal height of the lens, but my technicians can do all of this for us in the workup, where in this case, we selected, a Blanchard one fit lens and allowed the equipment to predict the starting lens. I just pass that right off to my technicians. They place that lens on the eye before I even see the patient, get an evaluation over top of it with an autorefraction and OCT so that we can see how high the lens is on the eye, and then we go from there. Usually what I do at that point is get the power and then go back to the ESP to customize the lens design and usually choose a lens that's profilometry driven. In some cases, we'll go ahead and go off of our trial set if it looks great. But since we have the ESP, we may as well customize it. And this is just an example of how easy that is. And there's the other eye. Simple as that. Now, getting into more complicated cases. So that's kind of a general overview, just briefly, of just a really quick utility of how we work up a patient, and then we can select a starting lens, get it on the eye, move forward quickly with great success. What about those ones that have complications? So this is great because we started off our presentation today talking about lumps and bumps. And so I had a doozy, and he looked something like this. So first of all, a little bit of background. This is a male. I believe he was in his early 30s. I'm quite certain, actually. He was referred for kind of an urgent contact lens fit because he needed cross-linking on the left eye, but had no usable vision in the right eye, had never had a lens before. So we had to get him into a lens. He came to us with a prior lens fit, and it looked like this. So he had been in a lens, but he wasn't able to wear it because it looked like this. And so we had a situation where we needed to kind of make a decision. Are we moving him into, a vault, a notch, freeform design? This is a pinguecula that is, being pressed down with a lens that's more of a spherical shape. And so we know we've got to do something different for this case because he couldn't wear the lens. Here's his profilometry. So what we did is you take him out of his lenses, get him into, get him measured with the ESP. The height, the red is that high spot that you see in this picture. And when we turn it on its side like this, we're starting to see kind of the height of that elevation. There it is there. So we can see very clearly a spot that needs to be vaulted. And for this patient, gave him options. So he had a choice for, using a lens with a vault or a notch, a micro vault, or he was given the option because he traveled from out of town to go ahead and be fit with a freeform design. And he chose freeform. So that's what we did for him. This particular lens was on the first lens fit. And this is after it had settled. So we're still getting a little bit of blanching, but that I found was not avoidable because any higher, and we ended up getting a lot of fluid kind of flowing in. He was comfortable in this lens on a first lens fit with profilometry. So data driven, we built a lens that was able to kind of vault over this space. 20/25 vision, his only complaint was a little bit of movement with the lens. And I'll just show you kind of what it looked like on his first lens evaluation. So centrally, you can see in this OCT, those little specks are kind of a clue to me that we're getting a little bit of midday fog under the lens. And he did complain about it. You could see debris kind of floating around. This is just a very brief kind of video just showing the edges on a first fit lens that was data driven. Looks really good. Hard to see in this video, but on the temporal and in particular superior and inferior, there's a little bit of edge lift, which is where his movement was coming from. But again, those blood vessels all around are not blanching, and this is a settled lens, so he was comfortable and happy without having all of that irritation. Here's the fluorescein pattern on the first lens. And where we see fluorescein flowing through, what we do when we have midday fog, we want to kind of differentiate. Are we getting fog that's coming externally from outside somewhere, tears or from the external environment? Or are we getting that true midday fog that's kind of excreted underneath the lens? Now, in this case, there was a lot of kind of tear flow through. So we apply fluorescein externally and see where it flows in. And we're able to easily adjust the landing in those spaces where we're getting a little bit too much fluorescein flowing in, utilizing digital technology, data-driven with the ESP, and provided on the second lens, 20/25 vision that was comfortable and stable. So this is the opposite side, but he is very happy, healthy eyes, was able to wear the lenses full time. He actually ended up getting cross-linked and wanted the exact same lens design on his fellow eye. So that's what we did after that. So sad leaky junction. So this is a really difficult edema case. This patient was a 63-year-old Caucasian male. He started with our practice in 2018 as a referral with quite a lot of trauma, scarring, a really low endothelial count. Vision with glasses was very poor. He swelled with everything. So a soft lens, he swelled, a piggyback system, he swelled, hybrids, he swelled. Sclerals he loved, but his endothelial count on the damaged eye on the right, 1028 versus a healthy eye, 2653, helps to explain a lot of that. Here's an image of his edema. This is actually just from wearing a piggyback system with a soft lens. We ended up referring him for surgery. So there are some patients that you just can't get them to be healthy with a lens on. You can't let this guy wear a lens, even though he wanted to wear a scleral. He loved the comfort and the vision. Sent him for surgery. So he had cornea surgery in 2020, actually. And once he was sent back to us, his main complaint was that he wanted to be able to hike. He was getting dry eye, and so we refit him. Some of the things that we really paid attention to that have really evolved included looking at the HVID, the VVID, choosing a decentered optic to better kind of match his where his clear vision could be, using the highest DK material available. And in this case, fenestrations and channels were essential. It's probably one of the toughest edema cases that I've really had to deal with in the last couple of years. Here's his profilometry map. This is another view generated by the ESP, and you can see a decentered pupil. We have the ability to measure all kinds of things within the software, which is really cool to do because we can place all kinds of things. We can choose exactly where we want our fenestrations. In this case, we also built a channel all the way through. Without fenestrations, you can see a little cystic sort of bubble. That's flat down with no lens. And after he had had his surgery wearing a piggyback, he was able to wear a lens with no swelling, but this is what happened with his scleral without fenestrations and channels. So we moved him into a different lens design just to included 3 fenestrations, channel across. And the swelling, it's a little bit harder to see, but it's the same area, and there was no edema in that area once we added those fenestrations and more oxygen flowing to the eye, all data-driven and freeform. So we were able to eliminate his edema with the customized lenses, and he was able to hike happy. So there's our beautiful background once again. So now party hat eye. So this is one of my most commonly patients that I see that present great challenges. Eyes that are shaped with a steep proud graft that have a high elevation centrally, likelihood of having maybe close to touch in that kind of mid periphery and then drop off with edema. So here's a patient, had a history of keratoglobus, ended up with a PKP, The right eye is a prosthetic, non-seeing. So that really ups the stakes to me. That responsibility just quadrupled because this guy or this patient is relying just on one eye. Monocular patients are really, challenging because we have to do everything we can to, even more so, to really make sure that we're safe and that we don't take away the vision that they have. Now, this steep proud graft, you can see this eye is just shaped like, how are we ever going to fit anything on it? Had numerous fit failures for our, I would say obvious reasons, really difficult fit, and sent from out of province. So we flew into our practice a couple months ago. Here's his profilometry, and you can see that steep proud graft shape. And so what we get in these eyes is kind of a lens sort of dilemma where we have an area that wants to touch centrally, maybe even on that mid-peripheral cornea, depending on the lens design, and kind of excessive space in these areas. And that's terrifying. And I hope that somebody out there recognizes Home Alone, because everyone in my office, all the younger staff have no idea what this is anymore. But anyways, so that's very, very scary stuff. Now, this is what conventionally just a normal diagnostic lens looked like on this patient's eye. You can see even from the OCT, it's decentering terribly with that big belly eye. The limbus is just atrocious. You can see that huge space. There's no way that that is a healthy, safe thing to use. On these eyes, whenever possible, I always use data-driven freeform when I can. A lot of the time we can utilize data to also order lenses that are not necessarily freeform, but that are data-driven. Almost all manufacturers, we use a lot of our, Zen lenses and our One Fits and our Boston sites, and we utilize the data to help to design those peripheral curves in ways that are better than this. But you can see that presents a big problem in this patient. This is an example of mid-peripheral edema. So if we go with lenses that look like this, we have a difference from our baseline to our post-lens wear. And you can see that there's areas in that peripheral cornea where the cornea thickness is increasing. We're getting edema. That's a big problem in the long term. So we don't want to have that. We're going to end up with problems for our patient. This is an area where we can see the differences in that mid-periphery. Very, very difficult to fit. Now, data-driven, again, ESP, we, with this patient, just had to go with a fenestrated freeform design. And on the first or second lens, this was an iFit lens, and it was just amazing. So I'm going to just cut to the chase that data certainly worked for this patient. It really was the only way that we were possibly able to fit this eye. And finally, we'll go into just one last case, and we'll have just a minute or two for if there's any pressing questions. Tom, if you want to just get them ready, if there's anything good in there. I'm sure there's lots of good questions, but the mix and match. So patient, female, 56 years old, had never worn sclerals, lots of surgery and trauma on the left eye. The right eye, kind of run-of-the-mill keratoconus, sort of moderate to severe, but no surgeries, no good vision with glasses. And here's her corneal topography. Just as kind of a demonstration of how different the eyes can be. First round, didn't take an ESP, started a fitting process and fit with diagnostic lenses, very successful on the right eye. Left eye, just based on eye shape and history and trauma, had to go back and measure the ESP. So to my point, always measure both eyes so you can go back and get your data, do a full workup right off the bat so that you don't have to go back and repeat it later. This was a 3 lens to final on a fairly difficult keratoconic eye. Good result. I would say that's a great outcome overall, really wonderful. ESP driven on the other eye, you can see this is a much different eye and a much harder eye, 2 lenses to final, and data driven for the win in this case. So competition wise, I would say Profilometry won on this patient, but overall, there's so many different ways that we fit these lenses, and that at the end of the day, getting to that finish line is we're going to get there one way or another. Now, in closing, the reason that I included Namaste is not to talk about yoga, it's to talk about that we honor each other and each other's fits. I honor your scleral fits. You're here to listen to what I have to say, and I appreciate that. And so Namaste. Here we go together kind of in this community, this wonderful community of scleral lens fitting. Again, I wanted to thank all of you for spending this time with me, and thank the team at Eaglet for having us. Thank you, Tom, for the kind introduction, and for, of course, all the things you've done for me along the way. And I think I will pass this back off for the final few slides, probably from Tom.
That's great, Sheila. just wonderful, great cases. And of course, the photography is really excellent, really helps bring home those points, and fantastic tips. We do have some really excellent questions, and Joe DiGiorgio from Chicago says, excellent presentation. So hi to Joe. So I have some great questions. Dr. Sharon Ho, referring to fitting PKPs with scleral lenses and of course avoiding complications. She asked, what if you have neo already present in your graft? Would that just be an indication that to avoid scleral lenses and just fit in with a corneal RGP if possible?
I usually do whenever possible, and sometimes it's just not. I absolutely hate it when we have those cases, because the way that I approach it, and I've had lots of conversations with other practitioners about this as well, is weighing the risk and benefit. And what it really comes down to, if there is an alternative, if I have a patient that I see has bad neovascularization already, maybe a low endothelial cell count, definitely consider other lens modalities. But it's today with the things that we have available, like channels and fenestrations, a lot of times we can get really great oxygen to those eyes. And ultimately, if they can't see without a device, sometimes we'll move forward. And then in those cases, we're going to be monitoring very, very carefully. I'll see them back no less frequently than every 3 months. And I'll also send letters to their ophthalmologist just to let them know that this is what we're thinking of doing, so they could pull the plug if they don't like that idea.
Yeah, I think that's absolutely right. And in my case, I'm sure it's with you, the ophthalmologists that we cultivate referrals from, they're sending us these cases. They're sending us their grafts saying, fit them in a scleral. So the patient's expecting a scleral. Sometimes we tell them no, but I think, like you say, with all the tools we have, we can fit them successfully. I fit PKPs all the time, and some have challenges, as you've enunciated, but they can be successful. And then our good friend Tiffany Andrzejewski from Chicago says, how long, if they're wearing previous lenses, and I imagine she's referring to sclerals, if we're going to do a scan, how long should they be out of their previous or current lens before you do new scans or the original scans?
There's a few reports that have come out looking at this, and typically on average is recommended definitely more than 48 hours. In some reports, they recommend a full week. What I find in clinical practice, that's not practical for really any patient that I fit. And so my rule of thumb is definitely no less than 48 hours whenever possible. I have done the odd measurement, and you just have to go with the best you can. If they don't have usable vision any other way, then you kind of just have to do what you can do. Or maybe they don't have availability and you have to do both eyes at the same time. One tool that you can use if you're concerned about it and you really want to get more than 48 hours, ideally more than that, but that's usually what I say is 48 hours, is do one eye at a time if you needed to. And that's one way you could. Tom, do you do it any other way?
No, that's exactly right. One eye at a time, maybe, or if they can discontinue them over a weekend, see them first thing Monday morning if they don't have to work on the weekends. Done a lot, some real difficult cases where I had a young physician who had terrible eyes, and she can't see without some sort of scleral. So you do one eye and then the other. Dr. Cesar Rodriguez asked if it was okay. He likes to just pretty much put everybody, not fill the bowl, but put viscous tears in the bowl initially, maybe I assume 2 or 3 drops, then top up with saline to prevent the midday fogging, increase the comfort and so forth. And he asked, is that okay to do routinely? We do it all the time.
100%, yeah.
As long as they're non-preserved. And then, doctor, it is great. I wrote down, I had a question of my own that I wanted to ask, and Gavin O'Callaghan from Australia, who's tuning in, obviously, asked the same question. And that is, when you do make channels in scleral lenses to address the edema issue, do you initiate more midday fogging? Do you cure one problem and create another?
Sometimes, yeah, for sure. It definitely can increase the debris, and it's a fine line. Fenestrations can do that too. I've found I've had to alter the position of the fenestrations in some patients, whether, they have no effect because they're too far peripheral, and it's all relative to where the eye changes shape too. So for tear exchange, we tend to put them a little bit further in versus for like a lens that's sticking, a little further out. And I've had actually a lot of success with channels with no excessive tear or no extra debris. Sometimes though, if the channel is too wide or too high, in some patients, especially those with ocular surface disease, I have noticed that. And then it's all about the risk and benefit and, where is it located? Can they handle it? How much fog is it? If it's outrageous, you can't keep it. And I have a patient going right now that, we just have to. And so it really is about kind of weighing the risk and benefit. And in a lot of cases, I would say that it's totally fine without the debris.
And isn't it interesting, Sheila? Look at patients, and sometimes you see a lot of debris in their fluid reservoir, but they don't complain about it. It doesn't bother them. So again, you can worry about stuff if it's not a problem. It's not a problem, but it is one. Well, those are great questions, everyone. Our next slide, I think, Sheila. Yeah, we wanted to ask you, in your mind, you've been involved in this for many years, and you do the practice at the highest order. We'd like to know, what do you think it takes to become an expert scleral lens fitter? I mean, that's a high bar to me. I don't feel comfortable with the term expert. I think that the fun thing about scleral lenses is you're always learning. We're always learning, as you just said, from each other. But what does it really take to, get off the blue slopes onto the double black diamonds?
Are you asking me?
Yeah.
Oh, I'm honored. Everybody has to start somewhere. So I think that certainly I would say the probably most important thing is what we're doing today is getting together to gain information that's kind of the latest in technology. And you have to fit lenses, and you need to go after extra education, read peer review, evidence-based articles. So that there are, things that you have reasons for the decisions that you're making. And then I would say, experts kind of a tough one I agree, Tom, that's a tough one to swallow, but an experienced fitter for sure. The Scleral Lens Society is a great resource that you can utilize to start to get connected. And then of course, industry. So this is great to attend things like this, get out there to the contact lens conferences, and hopefully we can all meet in person. Yeah.
And speaking of that, I think we have a list of resources here to share with everybody. But the fact is, the more we know, the more educated we are, the better we can do, and the better outcomes. And you've demonstrated that. Yeah, and so we have some. There's a lot of resources, and it's great to have the equipment. It's great to have the tools for all the reasons that we've been talking about for these 3 modules. But it's important to us to continue to educate ourselves, and some of the resources that you were mentioning, the Scleral Lens Education Society, it's free to become a member. You just sign up, and they have great articles. They have archived webinars. The Gaspermeable Lens Institute has brochures, has pricing calculators, coding and billing and coding calculators. That's all free. They have a wonderful downloadable Scleral Lens FAQ. One of the great resources we have is from our friends Melissa Barnett and Dottie Fidel, the Scleral Success, which is a guide for fitting scleral lenses. That's a free download for people. And then of course, kind of something that the first thing I read it 3 times getting started, was Afe Vanderwarp's great guide to scleral lens fitting. It's 60 pages long. It's not product specific, but it just goes through all the facets of fitting. That is a free download. So all these things are free, and just take the time to teach, learn a little bit, start fitting. Afe Vanderwarp will be one of the keynote speakers at our 5th annual International Congress of Scleral Contact Lenses. And that is just really a month from today, July 23rd and 24th. It's in Fort Lauderdale, Florida. Afe is a keynote, as well as many renowned speakers. So I hope you all come to that. It'll be a very exciting meeting in person. For those who can't attend, there will be a virtual component to that, and that's free. Contact Lens Spectrum's an excellent magazine. I think we all contribute to that. And then, of course, for more information about profilometry, there's the Eaglet Eye Academy, where these presentations will be stored, and as well as the tips. And the great thing about Eaglet, and I can speak from working with them about 4 years now, is that they're very responsive. Eaglet's a small company. You can talk to the coding Rainer and Arnie and Fongers, and talk to them and learn from them. And they're always open to improvements. This software has improved greatly in the 4 years that I've been using it, and it gets better and better. So it's a great company to deal with. And I think, Sheila, that wraps it up. That's our ICSC meeting. Please go on, register. And we've arranged for a special discount for all the Eaglet Eye Care practitioners out there, not just practitioners, but anybody involved in Eaglet. We have a special coupon for you, and you see there Eaglet25. Just put that in the discount window, the code, when you register. And I hope to see you there. And Sheila, I think we'll miss you. You're going to be in the cool, rarefied air of Canada, and we're going to be, soaking up the rays in Fort Lauderdale. A little bit of a temperature difference, but anyway, it's a great program. Hope to see you all there. And I think we have one more slide with some contact information. Oh, big thank you to Dr. Morrison and of course the previous presenters, Barry Leonard and Jason Jedlicka. The technology's never been better. It's a very exciting time to be a specialty lens practitioner. Thank you for coming, and there's some contact information there on the screen.
Thank you very much. I appreciate it.